I want to go over a few of the, just a brief overview of what we know about why the symptoms of Tourette's occur. I know we'll eventually get to management and treatment and the various things that one can do for it. But I thought I would do this overview because it would give, it might answer a lot of the questions that people might have. So, and I'm going to keep it pretty, not too medical, not high powered, very plain English, so that it's understandable. But if I put this across, I think you'll understand what we know about why we do what we do in the form of tics and obsessions and ADHD and impulse control and all that sort of thing. I'd start off by saying that what appears to be the situation is that Tourette syndrome is it's a developmental problem, and we don't know all about it, but the same way we don't know all about schizophrenia and autism and what goes wrong in the brain as to why it happens. So I'll start with saying that very briefly, there is, I think everybody understands what the cortex is in the brain. You've heard the prefrontal cortex, which is the area of your brain that does your judgment and reasoning and sort of civilized kind of behavior. There's a motor cortex, which makes motor movements. And there's a much more primitive brain called the limbic system. And within that, there are things called the basal ganglia. I won't get into all the technical names unless people have questions for it. And we'll take the questions more, after I go through all this. So we have a cortex and which is the more civilized brain, where all your judgment and planning and reasoning and impulse control, all that sort of thing works in that part of the brain. And then the basal ganglia and the limbic system, and that is the primitive brain, which is more instinctive, things that are hardwired into our neurology that provide for instinctive measures that are for survival or for protection, just like sort of a mother bear and her cubs. The mother bear has these instinctive things to do to protect her cubs. Now, what happens is, what appears to be is that there are some genetic and environmental factors, and we'll go over those shortly, that what they do is they adversely affect the development and the maturation of all the circuitry between the different parts of the cortex and the primitive instinctive part of the brain. So, and they're called, I'll just mention the name CSTC circuits. That's a circuitry in which the more executive brain, that part of the prefrontal cortex, controls the more primitive instinctive brain. And what happens is that during development, during intrauterine development, and ongoing after birth too, there's a significant fragility. The central nervous system is very fragile in its development, and there's a lot of synaptic pruning. Just like you prune your trees every year, you clip off various branches here in order that the tree grows the way you want it to grow. There's a lot of snipping off of various ends of neurons, and this pruning is very susceptible to damage in the intrauterine and postnatal period. What are the things that cause it? Well, there are genetic factors which we don't know much about, but there are a lot of other environmental factors. Toxins, alcohol, like fetal alcohol syndrome, toxins, alcohol, anoxia, particularly lack of oxygen. You've heard the term cerebral palsy. That's usually from a perinatal, meaning around the time of birth, lack of oxygen. Now that's a separate issue with cerebral palsy, but what we think is that toxins and infections and certain viruses, in fact, will interfere with the development and the maturation of that circuitry of the brain between the prefrontal cortex, which controls sort of the overview of all your activity, and the primitive brain. And you get mismatching and miswiring of these areas. And what it results in is, depending on which part of the brain of the circuitry is damaged or interfered with in its development, this results in the tics, either abnormal movements, tick-like movements, and it also, depending on which part of the circuitry is affected, will result in some people, not all with Tourette's, but obsessional behavior or ADHD behavior, just conduct disorder, impulse control problems, and all of the things that go along with Tourette syndrome, tics plus or minus, obsessions, compulsions, ADHD type behaviors. And so that the underlying thing is that it's the circuitry that is interfered with, usually either prior to or right after birth. Now, a lot of the symptoms, of course, don't show up until the kids are 5, 6, 7, and we don't exactly know why that is. Some of this, what the circuitry does from the prefrontal cortex to this more primitive brain, it has inhibitory pathways. It sort of keeps a lid on all this instinctive behavior. Now, many of these instinctive behaviors are protective, meant for survival or for adaptation or for protection, and as your neurology develops, as your central nervous system develops, some of these behaviors, whether it's tics or obsessions, etc., you will outgrow them. The central nervous system matures sufficiently so that some of these more primitive kind of behaviors are no longer needed, and they disappear. And what happens with Tourette syndrome, with the tics and obsessions and ADHD problems, this maturation of the central nervous system is either delayed or never develops fully. And that's why there's such a large range of symptoms, from very mild to very severe. And so what about the tics? Now, where do they come from? Or when you want to move, when you want to, say, lift something or move your hand or whatever it is, there's a circuit, and I won't get into the technicalities, but there's a circuit that goes from the motor cortex, that's the part of your brain that makes your arms and legs and everything move. It goes from there to the basal ganglia, those that I'm talking about, this more primitive part of the brain, and back to the cortex again, and then your hand moves. It's sort of a relay pathway in which it has to follow. Now, what happens with tics, and why do they occur in light of this pathway that I just described? Everybody has had the experience where your finger, like, am I doing it here? Yeah, I think I'm on the thing. Your finger twitches, it'll start to twitch on its own without you doing anything, or your eyelid flickers a little bit from time to time. I think everybody's had that at some stage. You didn't start it, you didn't do anything about it. It's sort of like a short circuit in the circuitry of the brain that makes these little movements of your finger twitching or your eyelid twitching. And nobody thinks anything of that because it's so common. Everybody has had that. In a much more exaggerated fashion, that's what the tics are. They're random firings. They're just like random firings of this circuit between the motor cortex, the basal ganglia, back to the motor cortex, and you have a movement. You have like your arm will twitch, or your shoulder will shake, or whatever the tics are, or whether it's vocal tics, grunting or sniffing or whatever. These are random firing off of the motor cortex because of some imbalance of the circuitry in the brain, and it's a developmental thing that has happened. We have no real idea why it's happened, except maybe from a genetic predisposition or an effect of some toxin or infection or anoxia, lack of oxygen, and some other things as well. So that's the tics. They have no purpose. They're just random, and they're about as random and as meaningless as when your finger twitches or your eyelid flickers from time to time, except this is much more exaggerated. As far as the obsessions, where do they come from? Now, not everybody with Tourette syndrome has obsessive behavior, obsessive compulsive behavior. Obsessions they're either repeated or repetitive images or thoughts or images that they produce, or they result in anxiety, and the compulsions that go along with it are motor or mental acts that you perform in response to that obsession to relieve the anxiety. So where do these obsessions come from? One part of that basal ganglia that I was telling you about, the primitive brain, it seems to have a very major role. It's called the caudate nucleus, but I don't want to get too technical. The caudate nucleus, and what it does is it is the sort of the seat of where this obsessive, repetitive kind of ritualistic behavior occurs. And there are two kinds of obsessions. There's some that go along with harm avoidance, or in other words, if I don't check the doorknob 50 times, my mother-in-law will die, or something like that, something that you know is absurd or that is just totally unrealistic, but nevertheless it's there. Some obsessions and compulsions, or compulsive acts that you feel you must do, they are more in the line of the sense of completion or perfection. And this is the kind of compulsion. This isn't a tic. This is a kind of a obsessive and compulsive act in which you either have to have, when you're setting up your books on the table, you have to have everything perfectly lined up so it's perfectly straight and on the table and not angled off. Everything has to be precisely placed, etc. This is sort of again, it's not a rational sort of thing to do. You know that it isn't, the world isn't going to come to an end if you don't set up your books in a perfect order, and you don't make everything symmetrical, but you do it because you are compelled to, and that is because there's a reverberating circuit in this part of the basal ganglia called the caudate nucleus, and this persistent revolving, just like a revolving door sort of circuit, goes on and on and on and on and on, and it's very difficult for you to stop it. You have anxiety if you don't stop it. So where do these compulsions come from, obsessions and compulsions? Well, if you go to the idea of evolutionary psychiatry, there are many things that hardwired into our neurology and into the neurology of, it's much easier to understand in animals, that are done for protection or for survival or adaptation. Grooming is one of them, and this is one of the features with Tourette syndrome. Making sure everything is perfect with your hair and with making sure that you're looking perfect. You see animals do this all the time. You know, the monkeys in the zoo, if you watch them, they're picking away at each other's whatever they're picking out of their hair or their fur or whatever. There was a survival purpose for this. Contamination rituals, the obsessions that you have to wash your hands for an hour or 50 minutes or whatever it is. You know that that's not reasonable, but it's a compulsion which had in evolutionary times probably a useful thing. If you keep clean, you're likely to survive better and do better. There are mating rituals, which it causes a problem in Tourette's. For instance, like birds or dogs, when they meet each other, they sniff around and all the rest. These are sort of, or peacocks, they flare their feathers up, and you can come up with all kinds of mating rituals, which are patterns that are hardwired into the neurology of some of these older species, if you like, phylogenetically older species, which had a the mating ones had a purpose for reproduction, etc. And in us and people, all children have these sort of compulsive behaviors initially for protection, a security blanket, having nighttime rituals. The light has to be on a certain angle. The door can only be open, 2 inches or something of that sort. This provides security. So a lot of these compulsions and obsessions and compulsions have had a useful place as your nervous system is developing. And in Tourette syndrome, what happens with the obsessions and compulsions that we have, whatever they are, whether it's door checking or whatever the multitude of obsessive behaviors occur, what this is a lack of inhibition of these pathways that should be outgrown with time. And so what we have really is an abnormal persistence or excessive expression of some of these ritualistic behaviors that are no longer necessary, but haven't been inhibited because of a dysfunction in the circuitry of the brain between the cortex, your thinking brain, and the more primitive brain, which is basically composed of instinctive behaviors, which are hardwired into neurology. And the last thing I'll mention or just summarize a little bit, and then before we go on to management, but I'll take some questions beforehand, is the problem with impulse control and ADHD is attention deficit hyperactivity disorder. So what is that, and why is it happen in kids with Tourette's, or in adults too? I mean, I still have that. So ADHD, it's impulsive, it's distractible, non-compliant, impulsive behavior, and that behavior is it's also associated with poor response inhibition. In other words, you can't inhibit. You get upset about something, and you instead of thinking carefully about what you're going to do about it, you just lash out at somebody, and your whole civilized behavior disintegrates. So people that have ADHD, whether it's with Tourette's, and ADHD, by the way, of course, can occur on its own without Tourette syndrome, but it's a very frequent, probably 2/3 of kids with Tourette syndrome will have some degree of attention deficit and hyperactivity. Is that we don't process information in a conventional manner. We don't see things in the same way. We don't intuitively see things the same way that you do if you have proper development of your nervous system. And by that I mean that we are prone to have these incoherent meltdowns with very little provocation. And these meltdowns, they're sort of like explosive, defiant, age inappropriate, altogether out of character, instantaneous, explosive, defiant manifestations with to whatever the situation is, like somebody cutting you off in the traffic or something like that, or any, it doesn't matter what it is, anything that most people would say, oh well, let it go, it's no big deal, and whatever. People with attention deficit, the way this happens is the part of the brain that we know is sort of the seat of aggressive behavior, or disinhibited or uncensored behavior. That part of the brain, you've perhaps heard the term amygdala. It's a part of the limbic system. It's one of the primitive parts of the brain in association with these basal ganglia. And what happens is normally, whatever normal is, but in most people, let's say, the prefrontal cortex, that is your editor, your supervisor, that is your, well, I guess that's a good word, editor, supervisor, that sort of controls behavior, keeps a lid on erratic kind of behavior. And that area is the prefrontal cortex. That is your executive brain. That sort of keeps a lid on this behavior. And in Tourette syndrome, or the people that have ADHD on its own, but it's frequent with Tourette syndrome, the connections, again, it's wiring, it's connections between the prefrontal cortex and this limbic system, particularly the amygdala, that are miswired, or they haven't developed fully. They're developmentally delayed. Why? Again, for the same reason that I said at the beginning. The either anoxia or infection or alcohol or other toxins will interfere with the development of those circuits. And when you have interference in those, the prefrontal cortex no longer has a connection to this primitive brain, and your primitive, instinctive, irrational, inflexible, instantaneous behavior is unleashed, and you act out in a just like kids with the terrible twos, a temper tantrum, sort of that neurology is arrested at a 3-year-old level. And there's a very serious problem. That usually in people with Tourette's gives you more problem than more of a problem than the tics itself. This kind of behavior, that's what gets you into trouble. It's often, it can be, especially in older kids, misinterpreted as being on alcohol or being on drugs or something like that. And of course, people in society don't take very kindly to it, and it's a difficult thing to control. There are medications, we'll come to that, that will help with that. But it's one of the, probably, I think, the most difficult part of Tourette syndrome, that gives most kids the most problem, whether it's with school or whether it's with a job, holding down a job, personal relationships, and all the rest. There are certain triggers that make this happen. The triggers are if the person with this ADHD component, if they're subservient or not in command of the situation. They're very thin-skinned and defensive, and they take everything as a personal front, and they just lash out with this incoherent meltdown. And that meltdown, like I say, it's an instantaneous, explosive, defiant reaction, way out of proportion to whatever the situation was. And there's a very primal, sort of a primal character to it. It's violent. It's like there's no thought, and you just lash out before you even think. It's not like ready, aim, fire. It's like ready, fire, aim. It's sort of in that backwards way. It's out of there before you have any control about it. It's a very difficult thing to deal with, and we'll talk about the management for that. I think maybe what I'll do is stop now, and if there's some questions, and then I'll maybe some of the management factors will come up in the discussion as we go along, rather than me keep talking about it here. So, Simon or Melissa.
Yeah, Melissa, do you want to jump in there and read off some of the questions that we have, or whatever?
Did that come through, by the way? I mean, what I was saying.
Yeah, no, it came through very well.
Did everybody hear it? That's what I mean.
I'm assuming everyone has their audio working fine. Then yeah, most people.
Okay. Well, maybe Melissa could start with the questions or something, or the.
Yeah, no, I have them here. If you want, I can address them. I don't know why I'm listening.
Okay, sure. Do you want to check, Simon? Do you want to check this with everybody that it is working for everybody online?
Everyone here, Dr. Doran, has anyone heard his speech? Just comment in the chat if you have heard him. Just like, yeah, okay. I've got a yes from Jenny, yes from Lucas.
They could hear everything. Okay.
Everyone can hear you. Yeah, we're all good. All right. So the first question that I guess we can pull up here is a bunch of questions from just general.
Sure.
The first question is it frustrating? It is frustrating when the teacher calls home to complain about my son's disruptive behavior. What is your opinion on the best forms of treatment for children and teens who are struggling in the classroom with their tics?
With ticks, and just ticks, or anything else, or both?
Um,
Well,
I'm
I'll
a,
just go over it a bit. Yeah. Okay.
sure, yeah. If you want.
It's a the most important thing in this in management is, first of all, as far as the teacher that is complaining or calling about it, is that the teacher and all the other kids in the class should be apprised of and sort of educated about what Tourette's is. And you have to, you can't assume that they understand anything of what Tourette's is about unless they've been told. And now they may have read it on their own, but they have to, the teacher and the other kids in the class, especially if some of them are teasing the person with Tourette's, they have to, it's best if they're brought into the into the loop by explaining what tics are, what obsessive compulsive behaviors, what ADHD is, etc. And once first of all, once the other kids know about it, once the other kids know why some of the behaviors, and in this case, say the tics, why they're occurring, and it is not their fault, it is not the child's fault, and it's not put on, then those kids that are advised of it will often become the best supporters of the kids with Tourette's. They will, and if anybody else comes to tease those kids, they will say to the other child that just say new into the situation, will say, well, no, you can't do that. You can't bully Johnny around because he has Tourette's syndrome. And if kids can understand that it is something as real, a true medical condition, just like nobody would make fun of somebody with crutches or in a wheelchair. Most kids will know that. And the same applies for teachers. You have to bring the teacher into to understand what the underlying pathology is in the various features of Tourette's, so that she or he is not judgmental and understands that it is just as legitimate a medical condition as is diabetes or somebody paraplegic in a wheelchair, etc. So that's one thing. The other thing is that the teacher, it really is, what do you do about the teacher? You have to sit down with the teacher and the principal and anybody else that's involved, and you have to try to make the world for that teacher and allow accommodations for the child, make the world a little more user-friendly. And in the same way that nobody would question that, to say a child that's paraplegic, nobody would question that he needs a wheelchair, or that somebody on crutches needs a little help getting from one place to the other, or doesn't have to go out and run around in recess because he has crutches. Those are easy things to understand. The teacher has to be made to understand that it's okay to, first of all, to make the world a little user-friendly, have breaks for the child, let an arrangement that when the child feels stressed or the tics are becoming more stressed, more apparent or more florid, that the child, sort of an unwritten rule, that if the child feels that way, it's okay for him to just get up and walk out to maybe a safe room somewhere in the school, or he's okay to just pick up and go on and make some kind of sign to the teacher that indicates, I'm very upset, my tics are getting worse or whatever, and he can pick up and go out for 5 minutes, and that nobody says anything about it. Nobody, it's an accepted thing. That's the kind of thing that you have to do. But really, it's a matter of making the world more user-friendly and allowing accommodations. Some of the things that will, other things that, like, for instance, that child can have more time on a test or something of that sort, or sits in a part of the class where he is at the back of the class, where the other kids they don't see him. He's at the back of the class, and so his tics are less noticeable to all the other kids. In other words, you can't change the child's neurology, and you shouldn't try too hard to change the child's neurology. Rather, change the environment to accommodate the tics that or the ADHD behavior. So I think that sort of answers it.
Okay,
Go ahead
cool.
with another one.
Yeah, that's great. No, that's a lot of information, and I'm sure a lot of people will be able to kind of like take off points from that. My second question will be, can infants show signs of Tourette syndrome? And that might be a little bit of a simpler question, but that's one.
Sorry, say that again. I missed that.
Yeah, of course. Can infants show signs of Tourette syndrome?
I don't know. I doubt it. I doubt it. Now, or I don't know exactly the answer. Most symptoms will start about, the tics often don't start till 6, 7 years of age, and maybe a little later. Some of the behaviors, some of the obsessional behaviors, and the problems with impulse control, they often occur earlier. Mine was apparent when I was 3 or 4. I remember things happening to me that were, in retrospect, far earlier than the tics began. But at infancy, I don't think there's, I don't know 100% for sure, but I would say this, that in the development of child's neurology, there are milestones. There's a time when when the child can lift his head up at 3 months, and at 6 months they can sit up, and at 9 months they can start to crawl and maybe walk. There are various milestones. But as far as symptoms that suggest Tourette syndrome that you could pick up and tell ahead of time, I don't think there are anything in infancy that would do that, that would pin that down, because all of neurology is your nervous system is developing. Obviously it starts before birth and carries on after, but the movements that a child makes, like an infant, when you're holding them, their hand, they sort of grab aimlessly with their hand. There's no coordination at all. And now you can say, well, kids with Tourette's sometimes don't have much coordination, but all children have that sort of klutzy in coordination in early stage. And I don't think there's anything that you could pin down to say that's the earliest signs of Tourette's in infancy. You could say also, on the other hand, you might say, well, if this is developmental in around the time of birth or even before birth, because of the reasons I mentioned, like toxins or lack of oxygen, why doesn't it show up right away? And why does it show up at 7, 8, 9 years of age? Well, there's a lot of genetic conditions that have motor, for instance, which I think everybody has heard of. That's genetic, and the gene has been found for that long ago, quite well, about 20 years ago, I guess. Now, the symptoms there, that genetic abnormality was present way before birth. The genetic abnormality was there at the time of conception, but the symptoms don't start till you're 30 or 40 years of age. So what is it that happens there? Why didn't it, if the genetic abnormality was there at birth, which it is, why doesn't it show up for 40 years? There's a technical reason for that, which I think it'd be a little bit too much for me to go into. Other than that, what happens, that gene doesn't get expressed until age 40. So whatever genetic factor there may be involved in Tourette syndrome, is whatever it is probably there at birth, but the genetic expression does not show up until 5, 6, 7 years of age. Infancy, I don't think there's any way you could pick up anything about it. Go ahead.
Yeah, great. That's awesome. Thank you.
I just want to throw in, Simon, we had a question in the comments asking when we're going to be asking other questions. We have a few questions that we're going to be asking first that were sent in, but afterwards we're going to be posting questions in the comments where everyone's been posting so far.
Okay. And Melissa, you're there. Can you hear me, Melissa?
I'm there.
Yeah, good. Everybody could hear what I was saying before, eh?
Yes.
Yeah, okay, that's fine.
Yes.
Well, okay, we'll just do the other questions, and then you ask the other ones that come up, and we'll just carry on as whatever you want.
All right, yeah. So anyone who has a question can post it in the chat feature on this app. And I already have one from Jackie, who joined a while ago. One of the participants she said, I just wanted to chime in. I noticed your first tick was around Jackie here. Just want to chime in. My daughter and and I noticed her first tick was around 8 months. She had it for about a year. My son at infancy had other stuff like sensory, but no ticks till 3 or 4, and we knew they were 6 to 7. Okay, sorry, my bad. That wasn't really a question. That was a comment. But the question from Todd Howard here says, is there any evidence that mold is a contributing environmental factor?
Hold on. So really, there's two questions here, eh? Right? One about mold. Is that what
No,
you're
I'm
saying?
sorry. The first question, the first part of my speech was not a question. It was just a comment from someone, from a participant. The second
Okay,
one,
but I want to, can I just address that a little bit?
of course, yeah.
Before you go into the question? There is a thing called transitory tics of childhood, and very common. 15–20% of children, all children, have what is called transitory tics of childhood, often starting or noticeable 4, 5, 6 years of age, etc. And they last for maybe a year, maybe 6 months or something like that, and they're gone. And then there's never again anything of it, and no, and these children do not progress to a full-blown or a formal Tourette syndrome. So this is really I guess the whole idea of this is it's a spectrum, so that there are this thing called transitory tics of childhood, which is now whether they start at 8 months and whether you could call it that, I don't know. I doubt it, but I don't know. I'm not. Maybe others would. Other people who see a lot of children and infants with this, I guess what I'm trying to say is tics are common, but it's only Tourette syndrome when it lasts, as you've probably read in the books, definition, lasting for 6 months or more, starting at such and such an age, and lasting a year. And then you can put the diagnosis on. It's just like this autism spectrum. There's a whole spectrum of a disorder from very mild to very severe. And so the transient tics of childhood, which are common, maybe 20% of kids, maybe 25% of kids have them for a short time, and then they're gone. Is it the same thing? It's to some degree a miswiring, or it's not so much miswiring, but incomplete maturation, incomplete development and maturation of the central nervous system circuits that go from the motor cortex, that's where your motor function starts, to the basal ganglia and back again, this little pathway. If I had a blackboard, I could draw it a little better, but it doesn't matter. I'm trying to make it simple. And in the developmental stage, in the development of these circuits, which go on, these circuits of all these kind go on lifelong in neurology. You're developing circuitry in your brain lifelong. And one of the parts of it in that synaptic pruning that I was telling you, where these little bits of wiring going from one area to another are snipped off here and snipped off there, you get a bit of mismatching that will give you this chronic tics of, transitory tics of childhood, which lasts for maybe a few months, and that's the end of it. So for someone that was saying, can I notice a tic at 8 months? Yeah, maybe, but does it mean anything? No, you can't make anything out of it other than if somebody were to come to me, I'm a surgeon, so I don't see the kids with Tourette's in early stage, but if a child came to me as a physician or a pediatrician and they had a little bit of a tic, and whether it's 8 months or 4 years of age, I say, forget about it. We'll see what happens. See what happens in a year. Come back and we'll see if anything develops. And in most of them, it'll be gone. It'll disappear. Now, the other question was something about, did you say mold?
Yeah, I'll read it again. So is there any evidence that mold is a contributing environmental factor?
Not that I know of, but I don't know enough about it. I'd have to say I don't know enough. What I would say is this. It's possible, and the specifics of a specific mold, I don't know, but I would say about one of the other things that I forgot to mention as far as a cause is that and this is still controversial, despite that it's been around for 25 years or more. Many, not all, but many researchers have found that certain antibodies against specific bacteria, and in particular Streptococcus A. Now there are about 100 subtypes of strep A, and one of the subtypes, if you get it, it's one of those things that gives you strep throat, but not all strep throat does this. But when you get strep throat, a streptococcus by this particular Streptococcus A, and there are a whole bunch of streptococci, you develop antibodies against this strep A, and these antibodies are called antineuronal. In other words, against nerve cell antibodies, antineuronal antibodies, and it's called an antineuronal antibody mediated neuropsychiatric disorder associated with streptococci. And those that have read a lot about Tourette syndrome will hear the term PANDAS, P-A-N-D-A-S, which is pediatric autoimmune neuropsychiatric disorders associated with strep. And what happens is this, and I'll come to why mold might be a factor. Antibodies against the, not the streptococcal bacteria, that doesn't cause the trouble. Antibodies against the streptococcal bacteria, what they do is not invade isn't the answer, they attack. The antibodies that you make against this particular streptococcus attack nerve cells, and in particular, nerve cells that are involved in the circuitry between the cortex and the basal ganglia. And so it is what has been shown by many investigators. Some don't believe it, but certainly I've read a lot about it, and I think it's legitimate, is that these antibodies attack the brain cells that are involved in the circuitry, and the result is dysregulation, disruption of the circuitry, and as a result, tics happen, and it's mostly related to tics, not so much the ADHD and the obsessions. And when people get recurrent strep infections with this particular streptococci, what happens is that they might get a flare-up of tics, and then they get some penicillin for the for the strep throat. The antibodies, they settle down, they sort of fade away. The tics tend to, you've heard the tics wax and wane. They flare up for maybe a few weeks, and then they subside, and then 3 months later, the kid gets another sore throat. Antibodies right away come to the rescue of the streptococcus sore throat, but they also attack the nerve cells, and the tics worsen, and they wax and wane. And so this is the underpinning of this whole idea of this antibodies attacking nerve cells, causing disruption of nerve circuits, and in this case of Tourette's, they cause the tics. Now, as far as mold, I don't know specifically, and I haven't read it, but it's certainly possible. It's certainly possible when you get a mold, if you get infected by a mold, some sort of parasitic mold or whatever the organism is, you will develop antibodies against it. And so theoretically, yes, antibody against whatever the mold is that's whatever in your house or in your wall could attack nerve cells and do the same. All I can say is it's certainly a possibility, in the same way that it has been shown that anti-strep antibodies have done this. It's possible that antibodies that you develop against mold could do the same thing, but I don't know specifically. I just don't know specifically.
Well, that was very informative, and I mean, like that. I'm sure that answers the question. So that's fine. We had another one come in. Is there any? Okay, it's kind of the same thing, but I'm just kind of scrolling through a few of them.
Yeah, go ahead, sure.
So
what happened? Did you say something? I missed.
The other
Yeah.
one, mold, was a different question, Simon. Is there any ways to mold or change your tick specifically?
I feel like that one's kind of already been answered though, hasn't it? But you can, if you want to answer that one, that's fine.
Say it again. I thought it was just what I just said, isn't it? No.
Right.
Is there any, let me read it, Melissa. Is there any ways to, no, is there any ways to mold or change your tick specifically? So that, yeah, that's
To
a little
mold,
different.
to mold or change your ticks? Is that what you said?
Is there any way to mold or change your ticks specifically?
Oh, to mold, to change your ticks. Yeah, sure. And this is an important thing in managing the tick disorder, especially when the children get a little bit older, is that you can, I mean, there are a variety of things you can substitute and camouflage. And you should try to teach your kids how to do that, so that, I mean, if some kids have a spitting tick, which is not all that uncommon, that child, I mean, you know, that's pretty, that doesn't go over very well in society. And that child, I mean, you can sort of camouflage it a little bit by having him have a Kleenex in his hand all the time, and having his, like here, my hand over his mouth all the time. And you can modify it and camouflage it to some degree. Some of the ticks that people have, what you're doing is you're not getting rid of them, but you can. And I've said that they are random. Generally, they're random things that this random firing off of nerve cells in this circuitry that I told you about. So you'd say, well, how can you change that if it's a random firing? Well, the way you can change it, and again, without getting too technical about that, when we talk about the motor system, that's the sensory motor system. In other words, the sensory cortex, the sensory part of the brain, and the motor part of the brain are connected and interconnected. And when and this goes to the idea of premonitory urges that people have in association with the ticks. And by that I mean, when a tick happens, or you sort of feel it, and the way you feel it coming on, which in a way is counterintuitive, it's sort of against saying, well, it's random. Well, how can you feel it ahead of time? You don't really feel it ahead of time. I've looked into this carefully with myself. And people say, well, you feel it ahead of time, and therefore you make the movement. That would counter the whole idea of it being random, in other words, uncontrollable. But what happens is this: when that firing goes off in the basal ganglia, that little spark, if you like, fires off, and it sends a message to the motor cortex to flick your hand or shrug your shoulder or whatever. At the very same time, within, it's not even within milliseconds, and it's simultaneous. That firing goes not only to the motor cortex, but to the sensory cortex. So you feel something. And a lot of people are calling these premonitory urges. In other words, you feel an urge to, you feel an itch in your back from a mosquito biting you, or itchy, and you go scratch it. Here, what's happening is that the random firing of the motor cortex that makes your hand flick, or whatever, or your head shake, or whatever you're doing, instantaneously or simultaneously, that same firing goes to the sensory cortex, so you feel it at the same time. So that fits in with it being random. Now, having said that, because these occur, and all this happens within milliseconds, like, thousandths of a second, it's too fast for you to process. But if you know that you're going to do a tick that is sort of not you don't want to do, nothing obvious like spitting, or like something else, like poking your eye or something like that, because even though it happens very quickly, as your hand sort of goes to randomly go poke your eye, or to twitch, or whatever it is, you can redirect it. You can learn, and it takes practice, but you can learn how to redirect it to something that's not as obvious. So yes, you can change your tics to some degree. You can't really stop them completely. You can suppress them, and you often do in a situation where, you know, there's a lot of people around, or you don't want people to see you twitching or whatever. You can sort of, you tend to sort of, quote, save them up. It's not exactly what you're doing, because I've told you they're random. And I know it all sounds contradictory or counterintuitive, but nevertheless, when you have the situation in which the firing goes on, you can with a little practice, redirect. Now you have to be able. The younger kids can't do this. Their neurology doesn't allow them to do that sort of thing. But older kids can do that and redirect and substitute something that's a little less offensive to, say, people around you, or less noticeable. It's a hard area to explain, and I may not have explained it very well, but that's what we understand to be that, yes, you can. Now here's another thing that is very misunderstood. A lot of people misunderstand the difference between a tic and a compulsion. Now, compulsions you do have more control over. I've told you that there's a sort of an evolutionary reason for some of the obsessions and compulsions we have that are that should be outgrown with time, but aren't. Now, a compulsion to, you know, check the door 50 times before you walk out of the house or something like that. I mean, that's not a tic, that's a compulsion. They're very different. Now, there you can override it. Once you're very hard for young kids to do that, but once you're a little bit older, you can override the part of the circuitry from the part I told you about, caudate nucleus and the basal ganglia, of checking the door 50 times or whatever. You can override that. You know, it's a compulsion. It's not a random tic. It's a compulsion, and you can train yourself. And this is the background, or the basis of habit reversal and exposure and response prevention training. That is the treatment for obsessive behavior, obsessive and compulsive behavior. You can train yourself to override that compulsion. And this is a form of treatment for obsessions. This exposure and response prevention, or habit reversal training. An example would be you can train yourself, and it takes practice. If you have to check the doorknob 50 times, well, you train yourself to do it next time. You won't stop it. You can't stop it. There's no point trying too hard to stop it. But you can modify it, and the next time you'll get yourself used to checking it 40 times, and you might do that for a few days, and then you make it a plan in your thing that by next weekend you're going to make it only 30 times, or then 20 times. That's what's called a habit reversal or exposure and response prevention. Same with washing your hands. You wash your hands for an hour before you get out of the door. Well, you learn and you practice doing it. Well, I'm only going to do it for 55 minutes the next time, and then the next week I'm only going to do 50 minutes, and you can control that. But that's more controlling compulsions. The tics are more difficult to control, but you can modify them a little bit by what I've said about the habit reversal training. And go ahead.
That's perfect. I think Melissa's going to ask the next couple of questions, so I'll let her do that.
So
Sure.
we had another question submitted prior to the call. And this is someone saying, I have a 15-year-old daughter who was recently diagnosed with Tourette syndrome. This has been a difficult time for her as her tics came on quickly and some are painful. We have seen signs of her cutting her arms and thighs. Is this related to Tourette?
Sorry, say that last bit.
So aside from this has been a difficult time for her as her tics came quickly and some are painful. We have seen some signs of her cutting her arms and thighs, in other words, deliberately. Mm-hmm. Is this related to Tourette?
Yes, it can be. Certainly it could be related to Tourette, to obsessive compulsive behavior. That's, you know, OCD, obsessive behavior, can occur as a separate entity by itself. But again, about maybe half to 2/3 of people with Tourette syndrome will have obsessions and compulsions. And now this self-injurious behavior, cutting, that's what you said, isn't it? Is that what you said, cutting and that sort of thing. Now, there's a couple things about that. That does come under the category of self-injurious behaviors, comes under the category of obsessions and compulsions, because you have a compulsion to do it. Now, there's I told you that the underlying psychology of compulsive behavior, evolutionary psychology, that goes back to things that are useful for you, or at least in older species, like contamination rituals, grooming, hoarding things. That's one of the other compulsions, is hoarding. So you hoard whatever it is, whether it's that's a natural thing for in animals, particularly. The squirrels hoard nuts for the winter, sort of thing, and we hoard things now, and we fill our freezers for a month at a time. I mean, it's not the same thing, and you don't call it hoarding, but in effect, it's a survival or an adaptive compulsion, if you like. Although we don't call it a compulsion, it's just sort of in some, nowadays it's sort of common sense to do that. Now, as far as self-injurious behaviors, it is a compulsion, but it's certainly part of Tourette's. I certainly had it. I'll tell you the ones I had if there's time. But it doesn't fit into this business of survival or adaptation, or in other words, it doesn't have any useful purpose, or it doesn't appear to have any obvious useful purpose. And so even though it is a compulsion, because these kids that do it feel compelled to do it, you can say, is it really another side feature of their disordered or disturbed psychology, as a reaching out, or a what's the word now? Not sure of the right word that I want to get here. It'll come to me in a minute. But a reaching out for help, almost the way that pre-suicidal people will do this sort of thing. They will have these kind of behaviors, not to be suicidal, but to reach out, and it's an expression of the frustration that they have with everything that's happening to them. And so that it may be just a reflection of the difficulty that they're having adapting to all the other features of Tourette syndrome, the tics or other obsessions, or impulse control, things of that sort. And it may be just sort of a cry out for help, that indicates to them, or indicates to others, indicates to their family or to the teachers or whatever, that they're not just dissatisfied, but very upset about the whole situation they have. I had a couple that, now some deal with this. Another way that this can be associated with Tourette syndrome, the obsessions, and it's one that I used to have a long time ago when I was in grade 3 or 4 or something like that, is that I would, I don't know if you can see it on can you see my hand here? That I can't see it showing, but anyway,
Right.
on the back of my hand, there's the back of my hand. I would scrape it raw. I would just with a pen or a pencil or something like that. And I would do this in school. I would just scrape both of them raw, equally symmetrically, and until they were bleeding. Now, why would I do that? I don't remember what I was thinking. And then what I would do also would be in the olden days in the 40s, and that we had storm windows that you had to open them a little bit. And anyway, I would raise the storm window maybe 6 inches, and I'd measure it 6 inches up, and then I'd let that window come down on my hand hard, till it hurt. I mean, it really did hurt. And then I would try it a little higher, do 8 inches, and I would measure it. And I had no idea why. What am I doing this for? Other than to, and then I would go to school and I would sit my hands out flat on the table with the teacher there on my desk, and so that everybody could see that there was this bleeding hand there. So that's self-injurious behavior. What did it mean, and why did I do it, and why did it stop? I mean, it stopped. Obviously, the teacher phoned my parents and said, well, what, something's going on here. They had no idea what was going on, and I didn't know what was going on. But it is how it fits in with Tourette syndrome. Remember I said that one of the types of obsessions and compulsions is a feeling of perfection, feeling of completion or perfection. Now that's sort of a perverse way of saying perfection, but it was perfection in that I could sort of methodically scrape the back of my hands, have the window come down hard on it, just at home that would be. And to me, that was like an accomplishment. That was like an achievement, and I wanted everybody to see it. But I can't explain anything more about why it's its purpose. In effect, that the only explanation I can have is that it achieved to me a sort of like it was an achievement to be able to do this, let everybody see it, and but other than that, it was almost like that was an obsession or a compulsion to achieve something that meant something to me for no reason that I can think of then or now even, other than to show people that I could achieve that. I know that maybe that doesn't make a lot of sense. So what do you do about it? Now that's a problem, because there have been kids with Tourette syndrome that have literally become blind from poking stuff in their eyes until they have totally wrecked their eyes, and they are blind and permanently blind. That's some of the worst ones that I know of, that I've heard of. The self-injurious behaviors. So it's not just a cry for help like say a pre-suicidal person would do, just to get attention, not to get attention, but in a way, it's a matter of showing the world, if you like, showing the world an achievement that you could do, and that it gave you some perverse pleasure, perverse excitement, and in which you've sort of thrown caution to the wind, and you just wanted to show the world that you've done this, that you've achieved this, even though you can't even give a good explanation. Of course, the problem is that how do you stop it? How do you stop that? How do you substitute something else? Under those circumstances, that's very severe. Mine stopped. I don't know how or why, but the only way that is a place very much for medication, anti-obsessive medication, and there are a whole bunch of anti-obsessive medications. The serotonin uptake inhibitors, people know Prozac and Zoloft and Luvox and all those. They're antidepressants, but they're very good anti-obsessive drugs. And how do they work? In other words, what made me do this, not mentally or not intuitively, but what made me do this was a reverberating circuit in the basal ganglia, and in particular this part that I called that is named the caudate nucleus. There's a reverberating circuit that goes round and round and round and round and round that makes you do these things. Since they're totally, we understand. I didn't at age whatever it was, 8, I guess. I didn't understand the rationality of it all, but this circuitry makes you do these compulsions. And what Prozac does, and there are other anti-obsessional drugs. Clonidine is one. There are a whole bunch of them. I can't even think of the names right offhand. What they do is they normalize the circuitry, and you can see this on scans when you do brain scans where the they're called PET or SPECT scans, and that's where the brain, you've seen them on Discovery Channel or whatever, where the brain lights up. If it's very active, it's red. If it's not active, it's blue, and anything in between. And you can see that the activity in that circuit is normalized by these anti-obsessive drugs. And certainly under those circumstances, you can't talk the kids out of doing it. Talk therapy, when it's something like self-injurious behaviors, that requires some anti-obsessional intervention, medication like Prozac or clonidine or clonazepam. There's a whole bunch of them that, again, I can't even think of the names out of hand. That's a difficult area, but anyway, I'm not sure if I really answered that. I sort of gave my own example, but perhaps that answers what was asked.
Thank you. So we actually had a comment based on your reply, which was from Carrie. She says, it doesn't make sense, yet so many of us really understand you from experience. The experience
Say that, sorry, say that again.
She said, she's replying, it's not a question, but it's a reply.
Yeah.
It doesn't make sense, yet so many of us here really understand you from experience. The experience of things not making sense to others oftentimes.
Yeah. Well, they may not make sense, but I'm trying to explain what happens and what has happened with me. And I've had other of those compulsions. I had and even I can't explain why. Another one for me was, there was a stage when I was about mid-40s. I'm 80 now. But mid-40s, I guess, for whatever reason, and I don't remember why particularly, I just thought I should lose weight. I was a little chubby. I was 160 something, 162 or 163, something like pounds. And that's a little bit chubby for me because I'm not very tall. I decided I'm just gonna not eat very much. And over a year, I went down to 108. And that's, what is that? So that's like nearly 55, 60 pounds. That's a third of my weight that I lost over, I guess, about a year. And that's anorexia. That was a compulsion. And I felt generally great. And I thought, isn't this terrific? I look in the mirror. When I see pictures that were taken of me, I look like not exactly what came out of the concentration camps, nothing as bad as that, but not far off, because I lost from 162 or 3 down to 108 pounds. That's a lot. That's a third of my weight. And I thought, I looked terrific. And when I look at the pictures, I look like a skeleton. And everybody was, thought, what's wrong with me? And I felt good. And it was like a challenge. It was like this big challenge that I'm going to go down. I'm going to go down. I'm going to keep going down. And I ate almost nothing. I was working full time as a surgeon, and I knew this was stupid, but it was like a challenge. I'm going to do this. I'm going to see how far I can get. Just like with my hands, scraping the back of my hands, I'm going to see how raw I can get and how high the window has to be to slam down on it before I can't stand the pain anymore. And then one day, literally one day, I was walking up a hill, and it's getting hard to walk up the hill. I just was, I just wasn't. I was working full time, and and working a lot as a surgeon. I was up nights, days, nights, weekends, and everything. But one day I was walking uphill, and I said, "Oh gosh, I can't. This is hard work here." And I said, "Hell with this." I bought a box of Harvest Crunch and a jar of peanut butter, and I started, and the whole thing in 2 days. My whole almost about a year and a half of hard work that I really actually enjoyed. I thought, this is wonderful. What a great challenge this is, that I'm achieving this. I'm achieving this weight loss. I didn't want to lose that particularly, but once I started, I thought, I'm going to really work hard at this here. This is great. And then one day, literally one day, I said, enough, hell with this. And I bought this, and I ate the whole box of Harvest Crunch in one go, at one sitting, and the peanut butter jar over the next day or two. And then I went back up to around 160. Now, is that sensible? Of course not. It's irrational, and and I know better, and I knew better as a physician that it's not a healthy thing to do, but I did it. So, like this other person lady said, it's an explanation that I can only tell you what I felt about it. You know what it was? You remember I said that there is two types of obsessions and compulsions. One of harm avoidance or pathological doubt. In other words, if I don't check the door 50 times, my mother-in-law or something will die or something. This other kind is a sort of a preoccupation with completion or perfection. And that's what this was. This anorexia. I'm going to get down to this perfect imaginary weight or with the back of my hands. Another thing that I used to do in Toronto was when I would be waiting for a streetcar, and I don't know if everybody knows the little islands in the middle of the street that the street, you stand on this island in the middle of the street, and the streetcar comes up in the middle, in the middle of the road on either side of, in the center part of the road. And the streetcar would be coming, and I never did it, but I was so tempted to do it. I would, just as the guy was coming up to where I was, I'd stick my foot on the track and then take it away really quick. and the guys would, a few times the conductor would holler at, what the hell are you doing there? And are you crazy or something wrong with you? And that was this feeling of challenge of caution to the wind, and it was a compulsion, which I would put my foot down, and fortunately I was somehow enough that I could take it away before anything happened, before the streetcar ran over me. So does it any sense to that? Of course not. It's a compulsion, which I, unfortunately, in that one I could override, but therein lies some of the behaviors that I had, and doesn't really, it's not they're not great explanations, but there it is. Yeah. What else do you have?
So we have another comment based on what you were just saying from Heather. She says, I am dealing with that now with my 14-year-old son. I need to pay close attention with his OCD and need to lose weight. So it's another comment, not a question, but she's saying that she can relate with her situation.
Well, she says she can see it's real, and I can vouch for it being a real thing, and that's the only explanation is that these are reverberating, just like a broken record kind of pattern in the circuitry of the brain between this caudate nucleus, and we can see it's localized there when you do all these brain scans that have, they light up red, blue, and whatever, etc. You can see that's where it's like a broken record, and the circuit is activated when these things are going on. Very hard to break that pattern. If it becomes dangerous, and sticking your foot down in front of a streetcar is certainly potentially dangerous. I was this is when I was going to university in Toronto, so I was in my 20s when I'd be standing there with a streetcar. It's potentially dangerous, but I was able to override it. But when a younger child has this sort of thing, there you've got to intervene. You can't, because his neurology or his ability to counteract and to override some of these obsessions may not be strong, and you can't let him do something that's going to be harmful. You have to intervene, and some of those obsessions, like I was saying, like well documented people have gone blind by poking a pen or whatever into their eye, sometimes their thumb, into their eye until they become blind, and you just can't let that happen. There you do have to intervene. And that brings up another whole area about whether you should intervene with medications and that. The important thing in treating tics and obsessions and ADHD, The important thing is, first of all, there's a lot of mild cases, and many of the features may not rise to the threshold of needing treatment. And you should, choose your battles. You don't necessarily have to treat everything, get rid of the tics and get rid of the obsessions and the ADHD. You have to sort of figure, who are you treating? Are you treating the child, or are you treating the parent or the teacher? Or is a school telling you, get your child under control with some drugs or something, or we have to take them out of school or something like that. So you have to be careful there. You do have to set some kind of rules for these children. You have to teach them a responsibility and discipline to some degree. You can't, just like you can't shout fire in a crowded theater, you can't let them just do anything, especially with some of the, there's a sexual connotation to some of the compulsions that some of the kids have of inappropriate touching, and even though they don't mean it as that, it's the same as having a child, a peacock flash their feathers, or dogs sniffing around each other, sort of as a pre-mating ritual. Now, some of these the sexual connotation of some of the, they're not tics, some of the compulsions. These are compulsions, remember. The child has to learn not to do that. You can't let them get away with it. It's not a case of getting away. You either have to substitute it or remove it or change it in some fashion, because society won't go along with that. So you do have to choose your battles. And like I said, generally speaking, when it comes to Tourette syndrome, kids generally, they want to do well. Kids want to do well, generally. And sometimes their neurology just won't allow them to do it. It's beyond, it's not, all these things are not volitional. These aren't deliberate things that they do. Their neurology doesn't allow them to be quote normal, and so you do have to interfere. And generally, you want to allow accommodations that are reasonable, like more time on tests, or placing them in in their classroom in a place where they will not be as visible to all the other kids. Things of that sort, or a signal that they need a break, they need to go, and they don't have to explain anything. They can just pick up and walk out because it's been prearranged with the teacher, that sort of thing. And generally to make the world a little more user friendly, so that you don't put all the onus on the child to conform, but you allow accommodations that will that will ease the whole situation, not just for that child, but for the rest of the class and for the teacher and for everybody concerned. It's a bit of a balancing act that you have to do, and it's not that easy to do. But I think, and as far as medications, I mean, we didn't get into that very much. I can ask questions about it, but there are no designer drugs for Tourette syndrome, as everybody knows, I'm sure. There are certain drugs that'll work well for the tics, the neuroleptics. They're usually they are the same as the antipsychotic drugs like Haldol and Pimozide I forget the other name there's a few of them. They have a lot of side effects, and so you don't want to you just treat what's functionally significant. If there's a part of the symptomatology that is really causing trouble to that child or in class or whatever, look after that, but don't try to fix everything, because if you try to fix everything, you often will have more side effects than what good that you're doing. And again, you have to think, who are you treating? Are you treating the child, or are you doing it for the sake of the school, or for the parents, or for the principal, or for the teacher? And you have to be careful on that. So but when it comes to medications, like I say, there are certain of the neuroleptics that are good for the tics. For the ADHD, you've heard of Ritalin, and there are other drugs as well. These are the stimulants. You'd think that that's a counterintuitive, that these kids are overstimulated with attention deficit and you're giving them a stimulant. Well, in fact, those stimulants like Ritalin, they work very differently in adults and children. In children, they concentrate their effect. If you give a stimulant to an adult, it's a stimulant. It's like speed. And you don't want that. They're already in that state. But these stimulants like Ritalin, they have the opposite effect in children. And what they do is they tend to normalize the circuitry, the inhibitory circuitry that goes from that prefrontal cortex, the thinking executive part of your brain, to the more primitive part of your brain. They tend to normalize that and focus it so that the child can no longer has these incoherent meltdowns and things of that sort. And then there are a third set of drugs, the anti-obsessions. Now there are some are the serotonin uptake inhibitors like Prozac and Zoloft, Luvox, and there's a whole bunch of them. Effexor, there's a whole bunch, and they work quite well. And then there are other drugs. There's some antihypertensive like clonidine. So in that case, and what I'm saying about that is that you can sort of use like polypharmacy. You pick and choose the symptoms that are most troublesome and look after those. And these combination of drugs, you want to be careful, but it's sort of like, when you go to the drugstore and you have a cold, you get Tylenol sinus or Tylenol flu and whatever, and there's a whole bunch, Tylenol cough or you know what I mean? There's a whole series of these various combinations. One is better for sniffles, and one is better for a cough, and one is better for their concoction is better for congestion, sinus congestion. Yeah, like, was it Advil, cold and sinus, all those sort of things. So these are sort of tailored for specific symptoms. And in the same way, it's reasonable to treat you don't want to treat the whole problem if the whole collection of symptoms. You want to just pick what's significant, what's functionally causing a problem, and go after that and use it. There's nothing wrong with medication, and there is a place for it, certainly. And just like you wouldn't, you treat somebody with diabetes, you give them some insulin if they need it, or whatever other medication that you might use, and for an antibiotic for a certain bacterial infection. And in the same way, for the various features of Tourette syndrome, there are specific medications that help it, but you should be cautious and conservative, and that's sometimes not easy to do. Anyway, go ahead, Melissa.
So we're going to be able to close off with that, Dr. Morton Doran. So, but thank you so much for answering these questions. But we still have a few more questions. But if you would be okay with it, would you be able to answer them a little bit later, and we could publish them, and people could still have their questions answered?
Yeah, sure. Like, how would I publish them? You mean like right in my?
We can talk about that after the call, but we can.
Okay. All right. Oh, sure.
We can work it out. So.
Sure. Yeah. Of course I would. Yeah. I may not be able to answer them all, but I think I could. I'll give you my ideas anyway about. Sure. Of course I could do more. Sure.
Thank you.
Okay.
So. Other than that, thank you for coming, and I think Simon put it in the comments that we do have support groups for adults with Tourette, for parents of youth with Tourette, for youth with Tourette. Now we're starting one for kids with Tourette. So if you're interested in that, you can go to the link that Simon provided, or you can write me at virtual@tourette.ca. So, and we're going to be having more events like this, hopefully in a few weeks, and you guys can give a good cheerio in the comments to Dr. Doran. And we actually had people saying so much. Thank you so much. This was absolutely terrific. Thank you so much. We would love another session. See, we can have you back.
Yeah, sure. I can, if you want to set it up, I'll come. I'm
Yeah.
retired now, so I got lots of time.
Now we're gonna try and make this sort of thing, these webinar sessions, a little bit more frequent now that everyone's home and from the pandemic. And
Sure.
even afterwards, when the pandemic is over, we're gonna try and see if we can make this more of a frequent thing. And we'd love to have you back, Doctor. This was very, very
Sure.
important. And thank you so much
Sure.
for all the knowledge you had to share with us today.
You're very welcome. Just let me know if you want to do it again. I'm around. Yeah. Okay. Is Melissa going to come back on or what? Or are you going to phone me on the phone later or what?
And we're going to end the call here. So
Okay.
I guess the end meeting and everything will go poof, Dr. Doran.